Welcome to the Overlake Reproductive Health IVF tutorial. Format. If you have not yet had your injection teaching, it is likely that your injection teaching will clear up any remaining questions. If not, please schedule a reconference with either one of us physicians. There are various protocols. You will either be on an antagonist protocol, that is the majority of patients, or a FemFlare protocol. In either case, you will receive specific instructions for that protocol with your calendar. All retrievals will result in cryopreservation, freezing of the embryos or eggs for replacement in a later cycle. That will occur approximately 6 to 8 weeks later. The only exception would be synchronized donor egg cycles or a synchronized surrogate uterus scenario. As the medical director of Overlake Reproductive Health, it is my job to go over the risks of the procedure, and we'll start that discussion with a risk of the drugs. The drugs will include Follistim, Menopur, and or Brevel. The three topics that we will cover in the next few slides are the risk of breast and ovarian carcinoma, the risk of hyperstimulation or OHSS, and finally the risk of multiple births. With regard to women's cancers due to fertility treatment, the current published data does not show an overall higher risk of breast cancer in women who receive fertility treatment. In a study of 87,403 infertile women, there was no significant overall increase in breast cancer, ovarian cancer, or endometrial cancer. A study of 12,193 infertile women did show a possible increase in breast cancer with a very slight increase in the odds hazard ratio of 1.98 with a 1.0 meaning no effect in women who ultimately never became pregnant. However, it is important to note that never becoming pregnant is a risk factor for breast cancer in and of itself, and this is likely the reason for that finding. With regard to ovarian cancer, the earlier studies were seriously flawed. Over a dozen recent studies are reassuring. Again, infertility is itself a risk factor. If there is any increase in ovarian cancer associated with the drugs, it is indeed small. The bottom line, essentially, pregnancy and birth control pills for that matter, which is hormonally the same as pregnancy, reduces the risk of ovarian cancer by about 40%. Therefore, the mitigating protective circumstances of pregnancy should more than outweigh any possible small risks from the drug. The fact is, nobody should be on the drugs forever. Our job is to set you up for success with the least number of cycles possible. With regard to ovarian hyperstimulation syndrome, or OHSS, I'm happy to say that severe cases are very, very rare these days. We have identified risk factors ahead of time that tell us if you are at a higher risk and taken appropriate steps with regard to both dosing and the protocol itself. Hospitalization is truly very uncommon. We have had one overnight stay in over a decade, but it is possible. Most often we can manage it as an outpatient with fluid removal in outpatient radiology if necessary. Multiple births. Those can mostly be avoided with single embryo transfers. That, however, is best done with PGS, or pre-implantation genetic screening, to ensure that a normal embryo genetically is being replaced. The incidence of a single embryo splitting to become two is less than 10%. With replacement of two embryos, the twinning rate is approximately 40 to 60%. Our goal, and the safest pregnancy, is a singleton gestation, meaning one baby at a time. With regard to the cycle itself, you will hear details later in this presentation. There are approximately 4 to 8 ultrasounds and blood draws during the cycle. At least one of us physicians will see every chart every day, and we, with the rest of the IVF team, make the cycle decisions. Unfortunately, there is a limitation to to what the stimulation drugs can do, some patients will simply not have good follicular recruitment no matter what we do. Cycles therefore will be counseled for a poor response, meaning less than 4 ovulatory range follicles, and by that we mean 12 millimeters or greater in size. The TVA, or transvaginal egg aspiration. What is it? You see here a schematic of how it is performed. We use a transvaginal ultrasound probe, in fact the same one that we utilize to monitor you. It, however, will have a very specialized and sterile probe cover over it and a needle guide which controls the needle movement in 2 of the 3 dimensions. One of us physicians will control the 3rd dimension. The procedure itself is performed under anesthesia. You will be asleep and we will not allow you to wake up in the middle of it. It proceeds through the vaginal vault. The ovaries live right on the other side of the vaginal wall. Each follicle is entered with a special needle under direct visualization on ultrasound. The risks are essentially similar to that of any surgery. The risks include anesthesia, infection, bleeding, damage to surrounding areas such as bowel, bladder, blood vessels, uterine, ovarian injury, risk of expanded procedures such as emergency laparoscopy or laparotomy, or even removal of the ovary called an oophorectomy, and even potentially risk up to and including death. I'm happy to report we have not had any of these complications, but they certainly do exist in the literature. Our goal is to get you through this procedure as safely as possible. For that reason, and unlike many other practices, we have an MD anesthesiologist at the other end of the table. ICSI and assisted hatching permits. Everyone needs to read and understand the risk and the benefits. The risks include damage, perhaps irreversible, to the embryo or egg, increased congenital anomaly rate for ICSI, although that is now understood that the increase in the sperm chromosomal anomaly rate that is present in men with sperm abnormalities is the major and frankly likely even the sole contributor. Amniocentesis is recommended for all ICSI cases and also for all women aged 35 and over, as well as all PGS or PGD cases. PGS and PGD do not take the place of an amniocentesis. Consent forms. They need to be signed and notarized. We have notaries available in this office. An appointment must be made to sign the consents in the office, and both partners need to be present and available together. Please read the consent forms before signing up for an appointment and initial the bottom of all the pages. I know there are a lot of pages, but truly it is important to read them. They are present for your education more than anything else. All consents must stay together. We cannot allow self-editing of the permit package. These are nationally utilized forms. Current understanding of IVF risk. The next topic we need to talk about is genomic imprinting. It is a process of gene regulation in mammals. There are 50 to 100 genes involved. One of the 2 alleles of a specific gene is silenced based upon the parent of origin. Imprinting is called an epigenetic process, and what that means is that gene modification occurs and is transmitted through a cell division or with mitosis, but without changing the DNA sequence. This involves very rare diseases, 1 in 13,000 to 1 in 15,000 live births. There's no definitive evidence for connection between ART procedures and epigenetic abnormalities in the children. We bring this up as a topic because there were some early studies that suggested that it might be a problem, but in fact there were significant methodologic problems with the prior studies, and recent studies indicate that infertility itself is likely the major risk factor for these abnormalities. Birth defects and ART. Infertility itself increases the risk of birth defects. This increase is seen regardless of whether IVF is used as the treatment. There is no increased risk of fetal chromosomal abnormalities with IVF, although there may be a slight increased risk with ICSI. If there is, it is likely related to the increase that we spoke of before of sperm chromosomal abnormalities in men with sperm issues, as well as potentially with paternal age. Frozen embryo transfers are not associated with an increase in birth defects. There is a possible increased risk of structural, meaning generally surgically correctable, abnormalities associated with ICSI cases and possibly also with IVF. IVF may be associated with an increased risk of placental problems, including low birth weight, preeclampsia and hypertension, abruption, meaning the placenta comes off prematurely, or previa, where it lies too low, and finally a potential and increased C-section rate. Early studies are now suggesting that freeze-all protocols with embryo transfer in a hormonally prepared cycle, which is what we do now here at ORH, may greatly reduce or even eliminate these risks. That in fact is certainly a major reason why ORH has moved to freeze-all protocols. PGD, PGS. PGD stands for pre-implantation genetic diagnosis, and pre-implantation genetic screening is denoted by PGS. The difference is as follows. Pre-implantation genetic diagnosis means we are screening for a specific genetic disorder. Pre-implantation genetic screening means that we are screening for chromosomal count abnormalities such as monosomy or trisomy. The best known trisomy is trisomy 21 or Down's syndrome. You can see that further denoted here. Known genetic disorders equals PGD. Aneuploidy screening, meaning checking for chromosomal abnormalities, is PGS. Family balancing is PGS as well. ORH does only day 5 or day 6 trophectoderm biopsy. We take between 6 and 14 cells from the region that will become the placenta. The inner cell mass, or the area that will become the baby, is not biopsied or damaged during this procedure. Additional specific consents must be signed for this procedure. PGS now tests for all 24 chromosomes, meaning the 22 autosomes as well as the sex chromosomes X and Y. Follow-up amniocentesis is always recommended, and again, as I noted before, PGD-PGS does not take the place of an amniocentesis. Fortunately, current technology means a very low error rate. It is less than 1%, but it is not 0. 8 or more embryos are ideal for simple PGS. 12 or more embryos are ideal for family balancing. For genetic diseases, meaning we're doing PGD, the ideal number of embryos is dependent upon the genetics of the specific disease being tested, and we will have discussed that with you ahead of time. ICSI as well as blastocyst culture are necessary, and while those are routine these days, in some patients that alone could decrease success rate. Day 5 or day 6 PGD-PGS does not change the biochemical pregnancy rate, meaning a low positive pregnancy hormone value, but no further development of the pregnancy nor visualization on ultrasound. But it does reduce the miscarriage rate due to chromosomally abnormal embryos. Day 5-6 PGD-PGS does appear to improve implantation rates per embryo. It will, however, take time to accumulate large data sets and studies on this new approach. But current studies indicate that a single embryo replaced with PGS would appear to be equivalent in terms of pregnancy rate to 2 embryos replaced without PGS. We are very good. Unfortunately, not everyone will get pregnant in a given cycle, but that doesn't stop us from attempting 100%. Biology, unfortunately, can sometimes be very tough. Next, I want to talk about the embryology laboratory itself. What happens in there? In the laboratory, your eggs and sperm will be mixed to produce embryos, which will be carefully cultured until the transfer day or cryopreservation, the freezing day. All of these laboratory procedures are timed according to your trigger injection. IVF Witness. Overlake Reproductive Health was the first clinic in the United States to adopt this technology. We remain one of a select few clinics in North America and the only one in Washington State that utilizes this technology. It allows us to electronically verify the identity of all samples that are used in the laboratory. Each sample container has a radio frequency identification or RFID tag attached to it. The RFID tag is recognized by readers situated at each workstation, and the first step in identification is for us to place an identity card into the procedure room reader that has already been assigned to your identity. You will confirm your name on the monitor before the procedure. When the egg collection dish is brought through to the procedure room, it already has your name written on it and an unassigned tag attached to it. The IVF Witness controller then allows for that tag to be assigned your name based on your identity card. All other dishes are allocated identity in a similar way, as there are RFID readers associated with every workstation in the laboratory. The sperm sample collection cup is also given an RFID tag, and it will be assigned to the male partner in their presence, and they will confirm the name on the monitor. The only time that tags with different names can be in the workstation at any one time is when they are linked as a couple in the system. If any other unauthorized names are placed within the work area, a very loud alarm actually will sound to indicate that they do not match. Prior to retrieval, your dishes are prepared with culture medium and labeled with your name. They are assigned a unique labeled position within the incubator and have an IVF Witness RFID tag on them. This unique position will ensure that your gametes, meaning eggs or embryos, are carefully identified. All dishes have their names checked whenever they are examined. So it is never just dependent upon the RFID tag. At the egg retrieval, each follicle is emptied in turn. The fluid is passed to one of the embryologists for examination. The eggs are easily visible within the fluid and can be removed to a fresh dish of culture medium. Once all the eggs have been retrieved, they are taken to the laboratory. At this point, they are rinsed and then placed into the incubator. On the day of egg retrieval, the sperm sample needs to be produced at some point during the morning. Someone from the lab will give a time. The time will vary due to lab workload. Samples can be produced at home, but please let one of the laboratory personnel know if that is the case the day before the retrieval, so this can be worked into the schedule. Each sample will be processed individually in a dedicated work area with only that sample present. After the sample has been prepared, it is left in the incubator until insemination time. The insemination occurs during the afternoon, timed according to the trigger injection. This will either be IVF, meaning conventional fertilization, or ICSI, intracytoplasmic sperm injection, depending on the sperm sample or the previous history, or if it's PGD-PGS, which requires ICSI. We will check the quality of the sample after you've produced it. Please don't leave the clinic before you've spoken with a member of the laboratory staff or a nursing staff member who has in turn spoken to the laboratory staff. All eggs are inseminated in IVF, but only those that are mature are injected during an ICSI case. The reason for that difference is that in an IVF case, all of the surrounding cells or nurse cells around the egg are left in place so that fertilization can occur. However, with ICSI, all of those cells have to be removed, in which case we know if the egg is mature or not, and only mature eggs are injected because immature eggs will not fertilize. ICSI. Seen here is an actual photograph of an ICSI procedure. You can see the sperm here, the injection pipette, and this is the egg. Seen here is entry of the injection pipette into the egg, and in the final photograph the injection pipette has been removed and if you looked really carefully, you could see the sperm. Fertilization check is carried out at 18 hours post-insemination, and this is classified as day 1. It is important for us to distinguish between normal, abnormal, and unfertilized eggs. We will be looking for 2 pronuclei, or 2PN, within the egg. That is, a male and female pronucleus, which is of course the DNA from the egg and from the sperm now moving together to begin DNA exchange and ultimately early embryonic development. This is a picture of a fertilized egg with 2 pronuclei. And you can see those. They look like egg yolks in the middle of the egg, but those are the 2 pronuclei. This is an abnormally fertilized egg. This egg has 3 pronuclei and hence is grossly abnormal with an additional whole set of chromosomes. This embryo would not be replaced. The embryos will be cultured further, examined, and moved at various times before they are frozen or cryopreserved. At each stage, development is checked. They will be transferred into different culture medium as their nutrient needs change. This is a picture of a 2-cell embryo. This is a picture of a 4-cell embryo, an 8-cell embryo. Blastocyst transfer. Extended culture, meaning to day 5, allows for the transfer of fewer embryos while still maintaining a high implantation potential. There is a risk that no embryos will be available for transfer because of arrested development prior to the blastocyst stage. This is reflective of metabolic and/or chromosomal abnormalities in the arrested embryos. In general, we expect that no more than half, or certainly less, depending upon the clinical case, of embryos will make it to the blastocyst stage. And, as a general rule, only half of those blastocysts will be chromosomally normal. Again, that number could be significantly less if and depend upon the clinical situation. This is a picture of 2 blastocysts. The round mass in the middle is the inner cell mass. That will become the baby. The blastocyst is essentially a fluid-filled ball of cells. The inner cell mass exists as a sort of island in the fluid. Surrounding the inner cell mass all along the edges are cells called trophectoderm that will become the placenta or afterbirth tissue. When we do PGD or PGS, we're taking cells from the trophectoderm and not from the inner cell mass. And as you can see, it is easy to tell the difference, in most cases at least, and if we can't tell the difference, those embryos are not biopsied. This is a hatched blastocyst. Yes, humans hatch too, and you can see the zona that this embryo came out of. Now it is ready to implant in the wall of the uterus. And all embryos must hatch before they can implant. Assisted hatching, where we help start the process, is carried out in a select group of patients, those that have a previously identified thickened zona, that outer covering, or in PGS, PGD cases. It is carried out in order to assist the embryo in leaving the zona, which it must do, as I said before, prior to implantation or for biopsy. Assisted hatching is carried out using a laser targeted at a very small area of the zona, allowing it to be breached in a controlled manner. This laser has been cleared by the FDA and as such is approved for use in ART clinics for the assisted hatching of human embryos. ORH has vast experience with this technology and in fact was one of the first 30 clinics in the country to adopt laser technology. This is an example of assisted hatching after the laser has removed a portion of the zona. Freezing. Only good quality embryos will be frozen. Embryo transfer. The chosen number of embryos are placed in a labeled dish for the transfer. They are then brought into the procedure room and you will be asked to verify the name read on the dish. You will already have seen your name and verified it on the computer monitor. After the embryos have been placed in the uterus, the catheter is checked to make sure that none of the embryos have been retained. Here you see an example of PGD. This is removal of between 6 and 14 trophectoderm cells from a day 5 or 6 blastocyst. 24 chromosome testing uses the latest single-cell technologies in microarray comparative genomic hybridization, or CGH. And very soon, next-gen sequencing will be adopted to test for chromosomal abnormalities. It gives us an analysis of copy number changes, meaning gains or losses in the DNA content of that cell and therefore the embryo it came from. If the previously identified and discussed targeted number of 2PN embryos are available, they will be cultured to day 5, biopsied, and then vitrified or frozen. If the target number of 2PN embryos are not reached in a stimulation retrieval cycle, they will be vitrified earlier at the 2PN stage and batched with additional embryos in subsequent stimulation retrieval cycles before biopsy and PGS or PGD are pursued.
Your IVF packet contains your calendar, protocol, prescriptions, pharmacy information, and other information about the process. Always follow your calendar. If you have any questions about the calendar, please ask, never guess. Your protocol has been chosen and tailored to you. Your doses of medications will be entered on your protocol sheet at your injection teaching appointment. Please read the consent forms completely and the instructions for completing them prior to the consent signing. IV sedation with a medication called propofol is administered by the anesthesia group from Overlake Hospital, named Matrix Anesthesia. We need you to bring a check made out to Matrix Anesthesia to your suppression check. It needs to be made out for $650 and is required whether or not you think your insurance plan will cover their charges. In terms of pharmacies, do not use a local pharmacy for the IVF medications. Local pharmacies do not have volume pricing, so are more expensive, do not keep these medications in stock, and are completely unfamiliar with them. Use one of the specialty pharmacies listed in your packet. They specialize in fertility and will overnight your medications to your home. They will be all clearly and properly labeled. Please note which medications go into the refrigerator, which do not. None of them go into the freezer. Your own natural cycle pattern has no bearing on the pattern you will see once you start NuvaRing or birth control pills. The NuvaRing or birth control pills are being given to put the ovaries at rest and to synchronize them so that the next step of injectable medications can work properly to bring a cohort of follicles or group and eggs to maturity simultaneously. Resting the ovaries is a necessary first step in the IVF process. The medications that make the eggs develop are Follistim, Gonal-F, Menopur, and Brevel. You will not use all of them, but you will use some of them. You will not ovulate. We will tell you when to start medications at the proper time to prevent ovulation from occurring. Even if you feel your ovaries or you notice increased cervical fluid, you will not ovulate. The protocol is a written out sheet with the doses of the medications prescribed for your IVF cycle. It will be called an Antagon protocol, a flare protocol, or a dual-estrogen progesterone protocol. Our physicians have determined the best protocol for you. Common to all protocols is an appointment called a suppression check. This appointment confirms that your ovaries are at rest. Please schedule this ultrasound and blood test on the date noted. Your injections start on day 2. Day 2 is just a name. It's not a day 2 of anything. It's just a way to count forward from that point. You may or may not have a period once you discontinue NuvaRing or birth control pills. It does not reset the calendar, and you do not need to call. Antigon protocols involve a medication called ganirelix. We will tell you when to start this medication. Unique to the FLAIR protocol is microdose or dilute Lupron. Due to FDA-required testing of this compounded product, many pharmacies have very short shelf lives. For this reason, we recommend that you get this particular medication from Strohacker's Pharmacy in Portland, Oregon. Their shelf life is the longest. Del-estrogen progesterone protocols are used for embryo transfer protocols, either recipients of donor egg or frozen embryo transfers. The appointment noted as injection teaching needs to be scheduled as soon as possible, and it must occur before your first injection. Consent forms must be signed and notarized with someone in the office. Please read all instructions for completing the consent forms prior to arriving. Once you have started the medications, you'll start having monitoring appointments, which involve ultrasound and blood tests to see how you are responding to your protocol and how fast or slow. This will allow us to narrow down when the retrieval is likely to occur. Besides the suppression check appointment, you need to schedule the first monitoring appointment for day 6 or 8 as noted on your calendar. All appointments after that will be scheduled by the IVF coordinator as you go along. The sole determining factor in when the retrieval will be is your ovarian response. Once that is idealized as determined by our physicians, the retrieval will be scheduled and you will receive detailed instructions for it, including exactly when to give the trigger shot. The most common trigger shot is Ovidrel, but at times Lupron is used. We will give you explicit instructions around giving that. The retrieval itself is done here in our office, and it takes about an hour and a half total time here. Anesthesia talks to you, and then they will get you settled in the procedure room. Your partner cannot be in the procedure room with you. The people who will be there are one of our physicians, the anesthesiologist, 1 to 2 medical assistants, and the embryologist. You will be put to sleep via IV sedation prior to anything potentially painful happening. You'll feel crampy and drowsy on the day of retrieval and cannot really work that day. You cannot drive yourself home. When it comes time for the frozen embryo cycle, you will be contacting the IVF coordinator when your period starts, which is usually about 10 days after the egg retrieval. A new calendar is prepared and prescriptions are provided for that protocol. The medications used for the transfer protocol are relatively inexpensive, and the protocol is much simpler than a stimulation protocol. There are different consents for the transfer cycle that will need to be signed, and another injection teaching must take place because the medications are different. Everyone gets a Valium for the embryo transfer. It is not a painful procedure, but for some people it is very difficult to relax when having a pap smear. If that is true for you, please discuss it with our staff, and we can arrange for light anesthesia as opposed to a Valium if you think that would be better for you. There is an additional cost for the provision of anesthesia for embryo transfers. After the transfer, we will give you some limitations in terms of activities, in terms of things you can't do for anywhere between 2 days and a week. There will be a blood test for progesterone 3 days after the transfer is done, and a blood test for pregnancy 14 days after the transfer is done. If you are pregnant, you will continue to see us in the early going of the pregnancy to follow the pregnancy with ultrasound and be sure that everything is fine. Ultimately, we can help you find an obstetrician gynecologist to deliver the baby and assist you in getting your records to them in a timely manner. Before you leave our care, you will be given discontinuation dates for all medications.